Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers, where we explore the latest in rheumatology care and education. I am your host, Amanda Mixon, and I am thrilled to bring you to a new episode packed with practical insights you can use in your daily practice. Today's topic is all about integrating the new ACR guidelines for lupus nephritis into real-world patient cases. These guidelines represent a critical step forward in optimizing outcomes for patients with this complex condition, and we'll break them down in a way that's actionable and patient-focused. Joining me today is the dynamic duo, Dr. Danielle Gatti-Palumbo and lupologist, lupus extraordinaire, Monica Richey, two dedicated clinicians and leaders in advanced practice rheumatology. Danielle and Monica bring a wealth of experience to the table, and together, the three of us will walk through a case that highlights the application of these guidelines in practice. It's also lovely because they work together, so that makes it even better. So Danielle and Monica, we've been lucky enough to have you on in the past, but for those who haven't heard those episodes, can you give us a brief introduction?
Sure. I'm Monica Richey. I'm a nurse practitioner. This year, making 20 years in rheumatology. Oh my God, I'm getting so old. It's so sad.
Ugh, I
But
know.
yeah, my 20th anniversary in rheumatology. Amazing. Time goes fast.
It really does. I literally tell my patients all the time, like, we're growing old together,
That's
um,
exactly
and
it.
it's so true.
Yep.
Danielle, what about you?
I'm a clinical pharmacist that is in the practice at Northwell, Long Island, Division of Rheumatology. And I actually started in rheumatology the first day with Monica. She onboarded to Northwell. So we actually
Yep.
started and we were in HR together. And that's kind of how I grew into rheumatology. So really working with the NP, she taught me majority of what I know about rheumatology. So I can say that in a field of where APPs supporting APPs, I think we're basically the spitting image of what that means.
Absolutely. And, again, I think, and I can say this with certainty, you both are practicing completely at the top of your scope, which is so much of what RhAPP is about is, giving people the tools so that they're able to practice at the top of their scope. So thank you so much. Welcome. And to those of you that are listening, please get settled in and let's dive into how these new recommendations can make a real difference in the lives of our patients. So I'm just going to go ahead and start by reading a case, and then we'll kind of all go through it together. So we have a 28-year-old woman with a 3-year history of lupus who's presenting to the clinic with worsening fatigue, swelling in her legs, and frothy urine over the past 2 weeks. We get some labs, and it reveals that she's got proteinuria of 3.2 grams per gram. She also has an elevated double-stranded DNA antibody and low complement levels. Her serum creatinine has risen to 1.6 from a baseline of 0.8. Ooh, that's kind of unfortunately what we see, but, a little scary. So obviously this patient's presentation raises the concern for lupus nephritis. So based on the new guidelines, how should we proceed with her initial evaluation and confirm this diagnosis? And then also, can you explain the role of proteinuria thresholds, complement levels, and the importance of a kidney biopsy in this scenario?
That's a loaded question,
I know, right?
Amanda.
It sure is. It sure is. But that's why we have you here.
So the first step is a kidney biopsy, right? If she never had proteinuria, you see the creatinine raising, that's a lot of protein, right?
Yeah.
The threshold is 0.5, right? For ACR, for EULAR. The threshold for proteinuria is 0.5. Normally is 0. In a normal kidney, you don't spill protein. Your kidney is good in filtering back all the protein back into the body. You start to see any hints that this is going on. So definitely the first step is a kidney biopsy. I think I spoke with you the last time that I go straight for the kidney biopsy. I send them to the nephrologist afterwards. So just not to waste any time, going from doctor to doctor, because she's going to need a kidney biopsy no matter what. And what was the other question? Because there was a lot of questions in
It
there.
was, yes. Well, and first I would just like to say, I think that's a really important teaching moment to understand that we can order the biopsies. I think I, for one, always thought, oh gosh, I have to get them in with nephrology. They're the ones that need to learn, do the biopsy. And that's just not the case. I mean, you really can order it yourself and you can talk to the pathologist. Obviously, yes, we of course want to get a nephrology team involved as soon as possible. But to that point, time is kidney. And so the more time we spend, the worse this patient can be. So I love that teaching moment because I think it just highlights that we totally can order these things on our own. You just have to learn how to do it.
Absolutely. Yes.
So the other question was, what about her complements being low, her double-stranded being high? What's the significance there?
Right. So by way of monitoring lupus, right? We monitor how high the double-stranded DNA is, and they have an inverse relationship for complements. Every time complements go low, that means that there is a consumption of complements, which means your immune system, particularly your B cells, are recruiting complements and affecting the kidneys, right? Complements are the missiles of the immune system. They are there to destroy bacteria. And in the case of lupus, when you start to see that the numbers are dropping, that means they're being recruited for all the wrong reasons. So if you start to see that the double-stranded DNA is going up, particular C3 going low, which has a direct relationship with lupus nephritis, so you start to worry that, something is coming. Let's say if this patient in particular didn't have any proteinuria, but he just start changings in the blood work, you start guessing that something, I guess, wicked this way come. But that's more or less how we monitor patients and try to, predict a flare.
Okay. And obviously the biopsy is so important because it tells us, do they have lupus nephritis? And if they do, what class is that? So a kidney biopsy is performed, and that's confirming class 4 lupus nephritis with active lesions. So unfortunately, this patient is sick. She expresses concerns about long-term side effects of therapy, and she's eager to understand her treatment options. I cannot think of anyone better to answer this question than a clinical pharmacist. So Danielle, what does the updated guideline summary recommend as first-line therapy for this patient? And how do we balance the need for prompt disease control with also minimizing long-term side effects? Obviously, some days she may want to consider a pregnancy, etc. So what would you do, Danielle?
Yep. So anybody with class 4 lupus, so initially anybody with lupus per se, we always want to make sure that they're on hydroxychloroquine and taking into consideration her age as well as possibly becoming pregnant in the future. Hydroxychloroquine is safe in pregnancy as well as trying to become pregnant. So it is something that she can continue and feel comfortable with continuing throughout her family planning if she anticipates that. Another agent that we would want patients with lupus nephritis or lupus to be on is a renin-angiotensin aldosterone system inhibitor, and these are your ACEs and ARBs. These are contraindicated in pregnancies, so this is something that you would have to probably revisit, but that's keeping basically kidney health and being kind of like your backbone therapy for these patients. But basically, first line, if a patient is not on hydroxychloroquine, guidelines do recommend initiating and continuing them on hydroxychloroquine to manage any and prevent any lupus manifestations unless contraindicated. And then from there, they do recommend starting triple therapy. So triple therapy means glucocorticoid pulse, IV pulse, or oral taper. And the IV pulse can be 250 to 1,000 milligrams of methylprednisolone daily for 1 to 3 days, followed by oral glucocorticoids of less than or equal to 0.5 mg per kg per day at a max dose of 40 mg per day, with a taper to a target of less than 5 milligrams per day by 6 months. You do this, you start these steroids even while waiting for the kidney biopsy and the histopathology report results. So you do want to make sure that you start those IV steroids or pulse steroids or even oral steroids immediately, especially if the patient does show some signs of protein in the urine. So triple therapy is including um, your glucocorticoid pulse or oral, in addition with an MPAA or mycophenolic acid analog. So this would be your Cellcept, your mycophenolic acid, and Myfortic, for instance, plus belimumab or a calcineurin inhibitor. And the calcineurin inhibitors would include cyclosporin, tacrolimus, or here voclosporin.
Great. I mean, again, it's a lot, and having somebody like you be able to explain it to the patient, also just so they understand, even something as simple as I have to tell you, not every patient that I've seen with lupus nephritis has been put on an ACE. Like I didn't really,
Right.
Early on know that they should be doing that in addition. And then kind of raises the question, like, should we be prescribing that? Like, et cetera. But it's so important to kind of preserve that kidney health. And obviously the hydroxychloroquine is so important. Step one. And I love how you said, like, if we're thinking about it and we think you have lupus nephritis, start the steroids. Don't wait for the pathology because, again, time is of the essence. Okay, so this patient, she is started on triple therapy with mycophenolate, your oral glucocorticoids that you described to us, and belimumab. Unfortunately, after a month, she still has persistent protein in her urine of 2.8 grams per gram, raising the question about escalating therapy. So, according to the guidelines, what steps should be taken to optimize her treatment plan? When might we consider a calcineurin inhibitor, and what patient factors should influence this decision?
So I will start because a month is kind of like a short period of time, and all of those, right? You haven't really given belimumab a chance at all. And the second thing I would do is I always, now I'm like paranoid. So I check mycophenolate levels on all my patients because they lie to your face. They tell they're taking it. I just saw a patient today. She's like, "Oh, I have 5 bottles of mycophenolate at home." I'm like, "Why? Why do you have so much mycophenolate?" And she kept telling me, "No, I'm taking." It's like, "Oh, hold on, like I have 5 bottles." Like, why? So obviously not taking it. So now I'm in the habit of every patient that comes in, do his mycophenolate. I check a level. So you don't know if this is a medication failure just because the patient knows it's not taking or it's just enough time. Right. Obviously, with that amount of proteinuria, you want to rush through it. So definitely you can opt to switch the belimumab for the calcineurin inhibitors because they have a much faster mode of action. And in that case, it's also recommended for class 4. So you wouldn't be off any of the recommendations or guidelines for sure. So I would probably make a switch.
Um,
Yeah, and even
yeah.
the guidelines do actually say, I think they even mention that if the protein to start off with is greater than 3 grams,
Yep.
um, to specifically use the calcineurin inhibitor versus
The
belimumab.
belimumab. Yep.
Mhm. If a patient has extra renal manifestations, then you would do triple therapy with belimumab. But if you have that high protein, then using a calcineurin inhibitor would probably be your first bet.
So, a couple of things that you said that really stuck out to me. Obviously, compliance is a big issue with our patients, and particularly like they're young, and think about what we were doing in our 20s, like if we were being, asked to take all these meds on a regular basis. So, I've definitely had those times where I'm like, they tell me they don't need a refill. I'm like, but you haven't had a refill in 6 months. I think you're due, but and then you have to question that, and then so really looking at your EMR to tell when a patient is filling their prescription because that can be kind of clue number one. Also, Monica, you mentioned checking mycophenolate levels. So I have not done that. Is it pretty easy to do?
Yeah, it's pretty simple. Yeah. In our lab, we just put mycophenolate level. It will come back in a couple of days. And you will know if it's high, if if it's within range or if it's low. I would say 90% of the time is low, and then, gotta call the patient back. Like, I don't think you're taking. Um, but yeah, it's pretty simple. At least in my MR, and in my lab, you can just order mycophenolate level.
Okay, that's super helpful because I have not done that. I know the one other thing I've been toying with is checking hydroxychloroquine levels. I don't know if you all are doing this. I know, I've heard lupologists say we really should all be checking this on our patients because they're mostly not taking it. But are you actively doing that too?
I don't do as much hydroxychloroquine, but I know my chief does.
Mhm.
He orders that all the time. Every single patient that he does, he check his hydroxychloroquine level. Um, so it's also a way to know if the patient is being compliant or not.
So interesting. Okay, so for our patient, she, because she's had this persistent protein in her urine, the care team decides to add Voclosporin to the regimen. Within 3 months, her proteinuria improves to 1.2 grams per gram and creatinine stabilizes at 1. The patient's concerned about ongoing monitoring and wants to understand the trajectory of her care. So, now that she's improved, we have to think about, how should her therapy and disease be monitored moving forward? What are the key parameters to track, and how often should we be reassessing her?
Right. So for the guidelines, every 3 months, right? Every 3 months, you should be doing urine. I'm a little bit, as I said, more paranoid. So sometimes I do check, like particular in that area where everything is starting to drop. I just leave ongoing orders for urine every month. I don't need the blood work, but I certainly need the urine. So I do that. But the guidelines literally say every 3 months. Um, as I say, in terms of monitoring, you can, since the medication is working, you see a drop in proteinuria, and I'll probably say the next step, start tapering off prednisone. It would be nice to minimize the amount of glucocorticoids these patients are in. So once I see that it reached that magical number of 1, I start taking it off. That's my guideline, okay? People, it's not the ACR guideline, so people understand.
And then
Danielle, yeah.
from a medication point, there's also some other monitoring that I wanted to mention. So there's definitely the nephrotoxicity. So you're going to do your urine analysis. You're also going to do your EGFR at baseline, and then every 2 weeks for the first month, and then every 4 weeks for the first year, and then quarterly while on the voclosporin. Um, your urine protein, like Monica had said, because voclosporin can cause some renal impairments, and there is a lot of dosing adjustments for voclosporin based on renal impairment and also any changes in their renal EGFR during treatment. You actually have to dose adjust during treatment. So it's important to always monitor the EGFR pretty closely. Hypertension is also very common with the voclosporin, so you do want to monitor and keep an eye out for that blood pressure. I know sometimes as rheumatologists, we don't really look at the blood pressure or consider it, more so primary care, but especially if they're on a voclosporin, you do want to monitor for blood pressures because you may need to add on an antihypertensive agent. Um, Also, it can cause hyperkalemia, so periodically just look out for the potassium. Monitoring signs and symptoms of infection, malignancy with voclosporin, it's still an immunosuppressant, so you do want to make sure you monitor patients, and patients may actually come in and say, oh, someone told me about, the malignancy risk. So, that's common with a lot of our medications, but it's still there with the voclosporin. Neurotoxicity is also another common symptom, so monitoring for increase in headaches, tremors, or maybe changes in mental status, and also QT prolongation. So, hydroxychloroquine alone can increase your risk of QT prolongation, but with the addition of voclosporin also has that risk. So you just want to make sure that with combination therapies especially, you do want to make sure that you're monitoring for that. And then side effect wise, most patients will probably complain of tolerability issues such as diarrhea, headache, cough, urinary tract infections, stomach pain, heartburn, and maybe possibly some loss of hair or alopecia. And you also want to avoid live vaccines with this medication.
All right, you just scared the bejesus out of
Yeah.
every patient right now, okay? I would not. I'm like, what? I'm just. But
It's
yeah, I mean, we have to be aware of that, but it's true. Yeah.
And I think, it's one of those things like you're right. Like we can often I mean, my gosh, it scares me to, even think about that. But also putting in the context of like, this is not forever, this is so that we can, so that you don't need a kidney transplant because
Basically,
that's
yeah.
so it's kind of one of those things that it's like, well, I understand that there are these issues, but the benefits far outweigh what the risks are as long as we're monitoring you. So I guess that's one other kind of just question that I have. Are you all doing EKGs on patients that you start hydroxychloroquine for? Okay, yeah,
No.
I am not either.
No.
I asked this question and most people say no. I did have one person that, was like, oh, yeah, I do it on every patient. I'm like, oh, I guess I don't. I haven't followed that yet. And, it's
No.
interesting because I never even thought about it. I think it was really kind of at the beginning of COVID when people were kind of using hydroxychloroquine, or whatever, that it kind of popped up. But yeah, I'm not. I guess if the patient was on several medications, of which
Mhm.
I would talk to my clinical PharmD about, like, and they had a much higher risk, maybe I would do it. But otherwise, yeah, I'm not doing
The
that either.
amount of the amount of interactions that come up or phone calls that we get for, the combination of hydroxychloroquine with another agent and oh, we can't dispense this because there's a QT prolongation risk. And it's like, it's just hydroxychloroquine. Like, yes, I know there's a risk, but we've monitored the patient before. Patient's not complaining of any heart palpitations or shortness of breath or anything. But it just we consider it more so when there's maybe high dose of other drugs that also could potentiate. But, just keeping in mind that voclosporin also has that risk, which a lot of our medications actually do come with that risk. So just knowing that, and if the patient starts to complain of anything, maybe, something to look for.
Yeah, it's again, I think it's just important for us to recognize, but with hydroxychloroquine really being the standard of care for these patients, I mean, you would really have to give me a solid reason as to why I shouldn't have that patient on hydroxychloroquine. I had a patient that just kind of incidentally was found to have a long QT in the ER for like something else, and she's on hydroxychloroquine. She's a young Hispanic lupus patient, and I sent her to cardiology, and I said, because they stopped the hydroxychloroquine, and I'm like, ugh, we really need her to be on hydroxychloroquine. So I sent her to cardiology. They were okay with me putting her back on it, and I put her right back on it because I was like, this to me, the benefits outweigh what the potential risks are. And, of course, I got the okay from cardiology, which made me sleep better at night. But yeah, it's like things that we have to kind of deal with, but also clinically have to think about what's best for the patient. Okay, so moving on with our patient. So awesome. She has really, achieved complete renal response within 6 months. We've saved her kidneys. And at 1 year, she wants to know about the duration of therapy and what adjustments might be made to her medication regimen. So, according to the guidelines, so what is the recommended duration of therapy, maintaining remission, and how do we tailor her treatment plan to minimize risk of relapse, but also kind of managing those long-term side effects? Nobody wants to be on medications forever and ever, right? Like no one does. And so, what should we tell her?
Then you want to talk about the timing?
So I think it depends on if the patient does achieve renal response after treatment. So if a patient does achieve that sustained renal response or complete renal response, the recommendation for the guidelines is a duration of therapy for 3 to 5 years. So not forever, but long enough to, like you said, prevent a kidney transplant.
Yeah, the 3 years is the mark for everybody.
Hmm.
And it's a tricky thing to keep the patients and that many medications for 3 years. So it needs a lot of hand holding. It needs a lot of like, teaching the patient. Right now, I have a patient who are barely diagnosed with lupus nephritis, barely started microventilator. It's like, oh, can I get pregnant? I'm like, no, please don't. So it's like, oh, how long is this gonna be? A month, 2 months? And I'm like, no, you're gonna be this on the next 3 years, and you have to be honest with the patient. You cannot say, oh, it's 6 months, it's a year, because it's a solid 3 years, depending how the patient respond and what is, if the drug continues to work and if there is no other complications from the lupus in the meantime.
Well, I
But
think again that's having those tough conversations because so many of these patients are young and they want to have babies. Of course, like I understand that, but I totally agree. It's having those open discussions, but also saying like if you are sick when you get pregnant, if you are not in
yep.
remission, it does not go well. I mean, and so that
Mm-mm.
could put not only, the baby at risk, but you at risk. I mean, we're talking, death, and so I think, once we set those expectations, at least in my experience, patients are, I think, more willing to understand that, yeah, I do want to have a baby and that is the goal, but healthy moms make healthy babies.
Absolutely. Yes, yes. And this is a patient who already had a complicated pregnancy when she didn't even had lupus nephritis.
Ugh.
So you really want to really set the tone from day one. They're not gonna be happy, right? Um, but they have to understand that this is not forever. It's not a 20-year medication. It's at 3 years. And if you do stick on it, it's less likely that this is gonna come back. So that's my contra, arguments like, yay, it's 3 years, but then you're gonna be great, just probably on hydroxychloroquine or belimumab or whatever maintenance medications we're gonna keep you on. Um, right. It's a sales pitch, unfortunately. But yeah.
Well, and maybe doing that, maybe helps with compliance, right? Like, if you aren't compliant with this, it's probably going to be a lot longer and we may have to escalate therapy, put you back on higher dose steroids, et cetera. So, I love how the guidelines really are like, no, you need to get them on, the steroids and then get them off. I mean, I've certainly had the patients, not that I ever use steroids long term in anybody. Yeah, right. Like we all have those patients, but that's like every time they lower below 15, they feel so much worse. And so, and it's like
Yeah.
having these guidelines also helps me say, like, no, this is what our guidelines suggest. Like the super smart lupologists of the world are saying this is what we should be doing. So, for at least for me, it's allowed me to have a better discussion with my patients to say, you should not like this. I am very firm with patients on steroids to say, the steroids are going to kill you a lot, way before the disease will if you stay on, 20 milligrams
Forever.
every
Yeah.
day. So our patient's done really, really well. So we're now at a 2-year follow-up. She continues to do well, but she's now asking, she's calling and saying, I'd like a consult with Danielle because I want to talk about the long-term strategies so I can reduce cardiovascular risk, manage comorbidities related to lupus and treatment. So she's like, I'd like to talk to Danielle and I'd like to talk to Monica as a team to discuss these things. So what are we going to tell her?
So first off, remember that lupus does have that cardiovascular increased risk. So it is an inflammatory condition, and all along any kind of immunosuppress autoimmune disease has a chronic inflammation that increases your risk for cardiovascular disease. So with that, you're also going to make sure that for her, monitoring a healthy lifestyle, whether that's the Mediterranean diet, smoking, cessation, eating a healthy diet, exercising, maintaining a optimal body mass index. If she has high blood pressure, possibly putting her on an ACE/ARB or optimizing those antihypertensives. If she has any history of clotting or history of TMA, then you want to add on anticoagulation, making sure her blood pressure is under control, like we had already discussed. And the ACR guidelines actually do recommend or actually go into a little bit on the adjunct therapy of lifestyle modification. So, like for blood pressure, I think they have a goal of 130 over 80 as the goal, and lipids, I believe, as being as optimizing an LDL of less than 100. But if they have like any MACE history, then it's less than 70. Maintaining calcium, vitamin D, so taking multivitamins. Patients that are on chronic steroids, you want to make sure that you probably do with DEXA if they're at that age of increased risk. And then just monitoring the patient on immunosuppressive therapy, making sure that they prevent infection, keeping well hygiene and, hand hygiene, especially if that's kids like me that's always getting sick. So just maintaining that healthy lifestyle will help with reducing her cardiovascular risk and long-term risk.
Monica, do you have anything else to add?
Yeah, I mean, cardiovascular is it's very important to me. And so all of my lupus patients are referred to cardiology, right? So I make sure that they go once a year, check their lipids and everything like that. Make sure that they're seeing cardiologists. Sometimes there's surprises. I have a patient who I sent to the cardiologist and turns out that she had Liebman Sachs. Didn't even know. There was nothing you could pick it up on an exam, right? It's just an echo, and she's been doing fine. She's on a baby aspirin. So it's always good because then they can do a a calcium CT scan. Always good baseline for all lupus patients. Um, check your lipids, all of that kind of stuff that can help you pick up any early cardiovascular disease, because that's, what happens to our young patients. They will have heart attacks more than postmenopausal women. So that is always a recommendation of mine for my lupus patients. Diet, obviously, like Danny mentioned, the Mediterranean diet, cut, you know, it's hard for you to talk about diet to patients with lupus when they're in prednisone. I don't even attempt to do that because they're eating the house away, right? You're 40 milligrams of prednisone. You're not responsible for what you're eating. So I don't even touch that until they're completely off the prednisone. And then, I try to refer them to nutritionists depending on their insurance. If they need weight loss, I'll send them to the weight loss center. It all depends. But I think that's the cardiovascular is something that sometimes it slips our minds, but I've been really good at sending everybody to a cardiologist that I don't have to worry about. I let the cardiology worry about that. So at least they see them once a year, just a baseline, and take it from there.
Are you doing that with just every lupus patient that you diagnose?
Every lupus and every RA patient, actually. I haven't been as good with PSA, but every lupus and RA patients, I'm making an yearly um, referral to cardiology just as a baseline.
We have a cardiologist that I work with who is really interested in preventative cardiology, which I think is incredible. It's kind of a newer thing. I mean, I feel like in medicine, we're so reactionary, right? Like we wait till you have the heart attack before we actually do something about it. But that's really insightful. I have to be honest. I thought about it, but I haven't really implemented it. And I think it's probably something I should be doing. To your point, to all the RA patients, the lupus patients. I mean,
Yeah.
probably like honestly,
All of
probably
our
all of our
patients. So,
patients.
yes, yes.
And especially if you have somebody that you know of that likes preventative cardiology, to send to them. They'll order the appropriate studies. They'll make sure, because to that point, I mean, I've definitely had patients that have unfortunately had a cardiovascular event, a stroke, something, and maybe it could have been prevented if I had sent the person sooner before there was the issue. I don't know.
It's hard to say, right? Because even patients who are in best control, these things can happen, right? You can't just put patients on aspirin just because, right? That's not the recommendation. There's no recommendation for that. But it's just a matter that, for me, it's a matter of like, oh, it's out of my mind. It's in the cardiology hands, and I don't have to worry about that anymore. If he wants to put you on a baby aspirin, then he wants to put you on a baby aspirin, right? But I think that, overall it's been easier since I put it in my head, like, oh, okay, I don't do it right away. I take a couple of months until like the storm settles. And then I'm like, okay, so now we're gonna just see the cardiology. You know what I'm saying? Because you can't just dump everything in a lupus patient. They'll get too overwhelmed. But yeah.
Absolutely. Well, that's super insightful and really helpful. And again, I think just shows that we really have to be comprehensive with these patients. It's not just treating the one thing. They have to Danielle, what you said with the blood pressure control. I mean, we have to be thinking about all of these things, which is why it's so important to work really multidisciplinary and find out who your cardiology APP friends are, like in your community, and call them up, and that way you kind of have an in. I mean, I think it's so important to connect with each other. And so, I think successfully we have managed this patient, and hopefully she can go on after 3 years to get off her medicines and potentially have a baby and do really well. So, thank you so much, Danielle and Monica. Is there anything else you'd like to just tell our listeners? I feel like I could talk with you guys for hours. It would make for a long podcast. I'm not sure we'd have people listening for the entire thing. So, but anything to just leave for our listeners?
On my end, always do a mycophenolate level. That's my. I just did one today. So
That's
yeah.
your clinical
So
pearl.
that is my clinical pearl, because treatment failure can be so multifaceted, right? You can have it just because they're not taking the medication, or there's no absorption of the medication. So, or the medication is just, lupus is pretty smart. So, your immune system can find ways to get around that medication. So you just have to figure out what before you keep moving from treatment to treatment to treatment, what is really why a patient is failing the treatment.
And sometimes with her mycophenolate patients, we do switch them to Myfortic, which is, enteric-coated. She also has done the liquid form for some patients
I
because,
do a lot.
mhm. So we have done that in our lupus patients as well, with her mycophenolate. So
Would that
sometimes
just be
possibility.
would that just be somebody that doesn't can't take the pill, or what would you switch somebody to liquid?
So I give the patients a choice, because there's 6 tablets of mycophenolate, particularly if
Okay.
you're going to put them on Voclosporin. That's the total of 12 tablets a day. So compliance goes very down. So I give them an option to go on, which is 1 tablespoon a day of mycophenolate, and you're done, right? It's 15 mLs and you're done for the day. So sometimes it's just easy. So you don't have that, you know, 13 pills to take a day, on top of the hydroxychloroquine, on top of the ACE, right? On top of the vitamin D. So everything, and then drop of the prednisone. So, you got 20 pills looking at you, you're not going to take it. So I try to get the liquid. And so that makes life easier for the patient.
Okay. And Danielle, I've experienced that same thing, like changing somebody from mycophenolate to Myfortic. They seem to tolerate it better.
Mhm.
So yeah, I totally agree with that. Danielle, anything else just to end with?
Make sure you always check for drug interactions. A lot of Monica's patients, I will tell you, especially lupus patients, they love supplements. I don't know if you know that. So they like to be very healthy, especially long term, and sometimes they will take a lot of supplements. So don't forget to ask about supplements because they do
Mm-hmm.
interact with a lot of the medications. Um, and compliance is an issue, but sometimes they do take their supplements. Um, so definitely monitor patients. Remember to monitor the kidney function, their livers function, even if they're, on other medications, and always consider drug interactions.
Always, because
Thank
they
you.
never tell you. Yeah, for sure.
And I know every time, this is awful, but every time a patient brings a bag of is it okay if I take this? I'm like, I have no idea. You know who would know the answer to that? A PharmD. So
Pharmacist,
why don't you
yeah,
go talk
yeah,
to the
yeah.
pharmacist
It,
if
it,
they can
it
tell
has
you?
been the rule that every once in a while I show up in the office and like, Dunny, what the hell
Yeah,
am
what
I
is it?
looking at?
And
Some crazy supplement that, somebody heard in the internet. They share stories. The neighbor brings it in,
mhm,
some aunt, and you don't even know what's doing. So, yeah.
yeah.
Absolutely. So after this, what we'll do is we will share Danielle's cell phone so that anyone can call and ask her about. Unfortunately, not all of us have clinical pharmacists that we can reach
Yeah.
out to. So it's super helpful if you do. So thank you again.
For
Thanks
sure.
so much. I so appreciate both of you and your insight. I'm so, again, I'm really fortunate because I can actually text you guys if I have questions. But that's why we're building this RhAPP community, so that there are ways that you can reach these experts. And with that, this wraps up another episode of RhAPPcast. Again, thank you so much to Danielle and Monica for joining us and sharing your insights and applying the new ACR guidelines to lupus nephritis. I hope that you have found this discussion to be helpful and inspiring for your own practice. Also, thank you to Aurinia, because without their continued support of APP education, this podcast wouldn't be possible. Don't forget to check out RhAPP.org for more information about our organization and the resources we provide for rheumatology advanced practice providers. Of course, you can stay connected with us on social media at RheumAPP on X and Instagram. You can find us on LinkedIn under Rheumatology Advanced Practice Providers. We have a new RhAPP ACE 2.0 app. I mean, that really is the place to see everything. There is a
Definitely.
forum where you can ask questions. And so really, again, if you do have a burning question that you just, I find sometimes when I'm around people I don't want to ask of maybe somebody that I don't want to look dumb, whatever. So there are no dumb questions, but that's a really great way to ask questions of, super smart people, of which I ask all the time. So again, thank you so much for listening. And with that, thanks for tuning in, and we will see you next time on RhAPPcast.
Thank you.
Bye, guys. Thank
Bye.
you. Bye.